Thank you so much, Alistair. And you just heard Dr. Raj talking about hepatitis C infection, and soon you'll be hearing Dr. Ekanaike about, all about the deranged LFTs. I don't really like liver. Not that, I don't see patients with liver. But the reason is, a few years ago, I was seeing a patient in the clinic with fatty liver disease, and I said, you need to lose some weight by diet and exercise. And patient goes, "Doctor, you need to lose some weight as well." And I lost confidence. I thought I'll, stay away from it, regardless. So we'll talk about GORD. So gastro-esophageal reflux disease is quite common, and we'll talk about the prevalence in a minute. But this is something, just the definition. It's the Montreal definition, and I'll talk about the classification as well. So essentially, we all reflux. I mean, that's normal. That's a normal physiological phenomena. However, if you reflux enough to cause symptoms or complications as a result, then it is termed as gastroesophageal reflux disease. Now, you can get a number of things with that. You could be quite symptomatic in form of typical reflux type symptoms, or you could have chest pain. Or if you were to do an endoscopy, you could reveal that patients could have esophagitis, stricture, Barrett's, which could lead into ADENOCARCINOMA. And then there are some extra esophageal syndromes which have been established, things like cough, which is very common. We do see patients all the time with that. Laryngitis, Dr. Lim talked about the laryngopharyngeal reflux as well. There's asthma people can develop, and dental erosion syndrome as well. And there have been some proposed associations, but it has not been proven as yet in any of the studies. But essentially things like pharyngitis, sinusitis, pulmonary fibrosis, ear infections, and so on and so forth. How about the prevalence? I mean, it's quite common, and this is the US data. And if you look at it, it's quite common. So if they looked at male and female patients starting from age group of 25 to 34 up until 65 to 74. And as you can see, reporting of GORD symptoms was quite common, seemed to be higher in age group between 35 to 44, and then it sort of plateaus down a bit. So that was, any episode. And if you look at least a weekly episode of GORD symptoms, it's a bit lower, but likewise, it was quite prevalent as well in all these age groups. How about the New Zealand data? Now, this is a very old study from John Wyeth, came out in 2000. He looked at 1,000, it was a population-based study in Wellington alone, and they had 1,000 adults they randomly selected, and they gave them a questionnaire. And the reporting symptoms in terms of dyspepsia was 35%, the reflux was 30%, and combined symptoms were noted to be in 45%. About half of them reported that they had symptoms about once a month, 19% had several times a week, and 6% had on a daily basis. Now, it is unclear whether they were taking medications or not. Regardless, that came out. So fairly common. So about 50% of these patients had reflux. Now, in terms of pathophysiology, it's a combination of things really. So it starts, within the, if you look at the saliva, it's usually alkaline in nature. However, due to a variety of reasons, if you get impaired acid neutralization, then it can't really, neutralize the acid as well, and that could sort of potentially cause reflux symptoms. Likewise, impaired esophageal motility. The most common or perhaps most studied is the lower esophageal sphincter, the inappropriate relaxation of it, and then hiatus hernias we know can increase the acid reflux issues as well. And finally, delayed gastric emptying or gastroparesis be due to medications or diabetes can lead to reflux as well. In terms of cough, just wanted to quickly mention, just because we see a lot of patients with a cough presumably related to reflux, and there are two main theories behind it. One is that they're reflux enough that they aspirate into the bronchial tree, and as a result they get cough. And the other one is that as a result of gastric refluxate, they get stimulation of the vagus nerve, and they elicit the cough response. So both of the mechanisms have been proposed. Now, in terms of risk factors, obesity has been something that has been proposed quite rapidly. And if you look at the studies, the severity of esophagitis correlates if you have a BMI of greater than 30 or more. However, conversely, if you were to lose weight, then that may not necessarily improve your reflux type symptoms. Smoking is also implicated, and the reason for that is because it lowers the lower esophageal sphincter pressure, and as a result, you get more reflux. And there's also acid neutralizing effect, which is enhanced by smoking as well. In terms of physical activity, interestingly, running may provoke gastroesophageal reflux disease as well, and that's to do with, again, lowering of the lower esophageal sphincter pressures. Medications. A number of medications have been implicated, and there are a couple of mechanisms behind it. One being impairment of the lower esophageal sphincter function, and as you can see, I've listed hopefully most of these. But things like tricyclic antidepressants are common. Diazepam, calcium channel blockers, all can do that. Now, more sort of probably used a bit more, and especially in elderly people, you see usage of bisphosphonates and dabigatran lately as well can cause significant esophagitis, resulting in reflux symptoms. Anti-inflammatories, aspirin, doxycycline are other medications as well, which can cause mucosal damage, resulting in reflux. Then there are things like pregnancy, and just because of elevated diaphragm and pressure and things like that. Connective tissue disorder like scleroderma, that's to do with esophageal dysmotility, and hiatus hernia we talked about as well. Clinical presentation, we talked about these. I mean, the typical symptoms are really heartburn and acid regurgitation. Atypical or supraesophageal, we mentioned about chest pain and cough and aspiration, pneumonia, toothache, and so on. Okay, this is something I think important. This is the phenotypic classification. Now, non-erosive reflux disease is common, and that's probably we see the most of it, and it is indeed 60 to 70% of the times you see it. So essentially what it means is you get symptoms, but there are no esophageal, there are no mucosal changes, and they tend to respond to the PPIs. In erosive esophagitis, you do get some inflammation as a result of chronic acid reflux, and you see it in 20 to 30% of times. Barrett's, you'd see advanced changes, and that is noted in 6 to 10% of the people, and these are the patients who can develop esophageal adenocarcinoma over a long time. Now, how about the severity of heartburn in terms of presence of esophagitis? Now, even if you have severe esophagitis, you may not necessarily have significant symptoms, and likewise, in presence of significant symptoms, if you did the endoscopy, there may not be significant esophagitis. So that's a very poor correlation in terms of symptoms and presence of esophagitis, which is so more severe heartburn symptoms does not necessarily mean they are going to have more severe esophagitis. So an endoscopic assessment may be warranted if you're worried. Now, I want to talk about the complications of GORD. So we sort of briefly mentioned esophagitis, and with chronic acid reflux, you can go on to develop stricture, so narrowing of the esophagus, and that results into dysphagia, weight loss, and so on. Barrett's can, with advanced changes into the esophageal mucosal lining, can result into Barrett's, which is indeed a risk factor for esophageal carcinoma and adenocarcinoma, and I'll talk about these in a little bit of detail now. So, in terms of esophagitis, we use a classification, and Dr. Lim mentioned that with grade C and D, you want to keep them on long-term PPI just because the risk of relapse is higher if you were to stop the medication. Anyway, we use, there are two classifications I've listed here, but the most common we use is this LA classification, so Los Angeles classification, and it all is dependent on how much inflammation really you've got. So this is the stomach here, and this is the mucosal folds of the esophagus. So if you have no longer than 5 millimeter, that's grade A. So if it's greater than 5 millimeter, then it's grade B. And if sort of they are kind of joined between the two mucosal field of mucosal folds, but less than 75%, then that's grade C. And if it's more than 75%, then that's grade D. So that's that. And then these are just the endoscopic images. So here you can see, so this is your Z line or squamocolumnar junction. So this is a bit of inflammation here, bit of inflammation here, as opposed to, so this is grade A, as opposed to here grade B, you can see the inflammation is involving most of the esophagus. So this is all ulceration and then a bit of redness there. This is probably a bit of normal area there. Okay. In terms of strictures, as I say, with long-term acid reflux in untreated patients, you can go on, so it leads to significant fibrosis and things, and you can develop strictures. Sorry, picture's not coming very well here, but essentially patients do develop dysphagia, and most of these patients would respond to treatment with dilatation, and although you may need to do more than one dilatation in these, but they seem to respond with that. Now, Barrett's is, as we all know, it's over long-term acid exposure. You can get intestinal metaplasia. So from squamous epithelium, it changes into columnar epithelium. So from this normal looking geojunction, it looks like this. And so this is the Z line here. So this is still all esophagus, but you can see it's looking different. So this is all Barrett's, and this is something which is considered sort of precancerous condition in these patients, and that's why we offer them surveillance. Okay, so how about association of Barrett's in terms of prolonged acid reflux? So what this graph here shows is that more reflux you get, and higher the chance of developing Barrett's esophagus. So if you look at this here, so you had very few episodes of reflux in the controls, and then if you had about 5, then you can have moderate esophagitis. If you have 10, you develop severe esophagitis. If you have 15 or more, then you get to Barrett's. So more acid exposure you have, higher the risk of developing more severe end of esophagitis or Barrett's. Likewise, if you had duration, so an untreated reflux, if you had more than, the reflux, in terms of number of years, higher the risk of developing Barrett's. So if you have less than 1 year, the chances of developing or having Barrett's on index endoscopy is quite low, less than 5%, as opposed to nearly 20-25% if you had symptoms for more than 10 years. So, more the exposure, higher the risk of developing Barrett's. Now, how about, so this is a study came out from Doug Reck's group from the US, and he looked at, in terms of if you did not have any heartburn symptoms, if you have, what are the chances of having Barrett's if you did not have any heartburn? So they looked at, I think, around 1,000 patients, so around 1,000 patients. So essentially, these were the patients who were to have colonoscopy. So they did gastroscopy as well on them, and more than half of them actually did not have any heartburn at all. So what they concluded from their study is that Barrett's is common in people with people above 40 years of age with no prior endoscopy. So that was one finding. And the other thing was the chances of having long segment Barrett's, so more than 3 centimeter of Barrett's, is uncommon in people who do not have any history of heartburn. So even if you were to have Barrett's, the chances are it will be a short segment one. The risk of esophageal cancer from Barrett's, there've been huge number of studies that looked into that, and the results have been variable depending on what study sort of you look at. So the true risk that has been estimated is about 0.5% per patient year. So the risk is real, and one of the absolute indications for these patients to be on PPI, as Dr. Lim said, is Barrett's esophagus, and if they were to have Barrett's established on endoscopy, they should undergo surveillance. How frequently that should be done, that is quite debatable and remains debatable still. Okay, so what do we do with our patients? Well, this is just a simple diagnostic algorithm. If you have someone presents you with reflux, you trial them on PPI. If they sort of improve, which most of them do, then you've got almost confirmation of diagnosis. However, if they have persistent symptoms, then you may wish to consider upper GI endoscopy. And if you really, even if the gastroscopy is normal, you could consider them for pH study, and that could establish whether they truly have reflux or not, and whether that's mainly due to acid or non-acid sort of related reflux disease. So this is a simple test which we perhaps all do. So anyone who presents with typical heartburn symptoms, you trial them on PPI. It obviously serves both as diagnostic and therapeutic tool. The sensitivity is 68 to 80%, but the gold standard, of course, is the pH test, which will tell you whether there's true acid exposure or not. Regardless, if it could be falsely positive as well, because even if you have responded, that does not necessarily mean it's GORD. It could be placebo effect. Regardless, you've got to keep the patient happy. So yeah. Well, some patients, fail PPI, and this could be due to a variety of reasons. Non-compliance, although patients admit that they take it all the time, but non-compliance is indeed one of the stated reasons behind that. One of the other things we've noted is that they got to take their PPI at least half an hour to an hour before the meals, just because once you've eaten, the acid is already released, and and after that you take it, it's not as effective. So that could be one of the potential reasons for failure, and that needs to be taken into account when discussing this with the patient. Also, the reasons could be if they have a large hiatus hernia. That means the risk of acid exposure would be high. So even though they're taking PPI, the risk is regardless is high. Or if they can get nocturnal acid breakthrough as well. Sometimes the esophagus is hypersensitive, so they could be refluxing normal amount of acid, but still it is quite sensitive, and that's why they don't respond to PPI as much. If they've got non-acid reflux, or if you've got the diagnosis wrong, or if it's all just functional. Okay, so when do you do additional investigations? It's something that one needs to consider if the history is not typical of reflux. If their symptoms are frequent, long-standing, or they do not respond to treatment, or if they have any alarm symptoms, in particular dysphagia, weight loss, any hematemesis, melena kind of issues, or anemia. Now this is a slide I took from BPAC, which you all would have seen, and again it advocates the same thing, that anyone with dysphagia or odynophagia in these patients with GORD should have an endoscopy. Likewise, hematemesis, or if there's no obvious explanation of weight loss otherwise. At the moment in the referrals, if they are at high risk, so for instance Maori or Pacific Islander or Asian population, then you send them at a younger age. Otherwise, 55 or older with persistent dyspepsia, so someone, they should have endoscopy as well to just to assess for possibility of esophageal and gastric cancer, just because they are slightly higher risk than population otherwise. Now, what are your goals? Well, first and foremost, you want to try and eliminate the symptoms. For some people, it can be quite troublesome, and they struggle in their life as a result of that as well. And then, of course, if you did endoscopy, if there's esophagitis, you want to you want to heal esophagitis, and not only that, you want to try and prevent any long-term complication as well. So if they were to have esophagitis, especially grade C and grade D, then you perhaps want to keep them on long-term PPI just to try and maintain remission as well. Now, in terms of diet and things, I mean, a lot has been said about that. Although the evidence is weak, regardless, you would say to your patients, try and lose weight. Sleep with 2-3 pillows, or head of the bed propped up. Quitting smoking, alcohol cessation, caffeine, excess caffeine can do that. Dietary modification, fatty meals can precipitate reflux, chocolate, that kind of thing as well. Although evidence is weak, regardless, you do sort of talk about this. I'll skip this slide, given Dr. Lim talked about this in detail. So just a quick one on anti-reflux surgery. So that's something that could be offered in patients who do fail medical therapy. However, these patients, even if they had surgery, in the long run, they may still end up taking PPI. So it may not be the answer to everything, but that's something one can consider. And just to mention, these are the predictors of success of surgery. So if you have typical symptoms, if you respond to PPIs, and if you have abnormal pH study and so on, experience of the surgeon is quite important as well, apparently, as opposed to if you have normal pH and Barrett's and things like that, then you may not do as well in terms of symptom control goes. Okay, this is all what I have to say. I think we'll be talking about questions.